People are on the beach this morning. and but I hope that for those of you who are interested in this area, this will be worth your while to give you time away from the beach. So, let me see. So the outline of today's talk, we're going to talk first about the epidemiology of opioid dependence in pregnancy. As we were talking earlier, my colleague from Turkey said that this is not a big problem here. And I don't believe that, but we'll talk a little bit about the fact that this is a big problem that is poorly recognized, not only in the United States, but throughout the world. I will also talk about the complications and the benefits to be gained from treatment, the risk-benefit notions, because everything in pregnancy is balance. And this talk is about balance, the balance of risk and benefits. I will specifically talk about one randomized clinical trial, the biggest of its kind, called the Mother Study, in which we compared buprenorphine to methadone during pregnancy. And then finally, a few words about the implications of our findings. So, the magnitude of the problem is very difficult to determine. There is likely under-ascertainment. It is likely very underreported because of the stigma associated with the use of opioids in pregnancy. In the United States, the most recent comprehensive figures are from 1992, where it is estimated that 53,000 U.S. babies were exposed to opioids during pregnancy, and most of these in those days was due to intravenous heroin by the mother, used by the mother. In 2008, there were 114,000 new heroin users in the United States. And another bit of information, that 15% of pregnant women in addiction treatment had heroin dependence in 2008. And this number, is the 15% heroin dependence, has really not changed very much in the last decade. Now, in the United States, in 2009, the number of people treated over the age of 12 years of age for each of these different substances is indicated here. And you can see that heroin now is much less than pain relievers, than analgesics. And this is a result of the fact that over the last decade, there has been yearly increases in the number of analgesics, and this is in thousands. So you've got 739,000 patients treated in the last year in the United States over age 12 with pain relievers or analgesics. So the problem is one of non-medical prescription analgesics now, rather than heroin. There are 2.4 million new non-medical prescription analgesic users in the U.S. in 2003. And the treatment admissions for prescription opioid dependence has increased fivefold, from 1% to 5% during 1997 to 2007. Now, there's a real problem in the United States, and that is our health insurance system, our health care system. Only 10% of the 23.5 million persons over age 12 who need addiction treatment in the U.S. actually receive it. 10%. So you can see how difficult it is to identify the magnitude of the problem because so few of the people get treatment. I mention our healthcare system, but that's only a small part. I think the other part has to do with physicians not recognizing these disorders. And as one of my colleagues in the audience mentioned, the notion of iatrogenic, physicians prescribing these medications and causing the problem. So what this means is that a very large number of the women in obstetrics care have unrecognized opioid, especially analgesic dependence, needing treatment. And this shows a map of the United States, and it indicates in red those areas of the states that have the highest rate of pain reliever dependence. And I am located in Tennessee. Vanderbilt University is in Tennessee. And you can see that we are in a very, very hot spot in terms of analgesic use. And this is, to me, this is our data. My colleague Richard Epstein developed this data. It is the proportion of pregnancies among TennCare enrollees with first trimester opioid use. Now let me explain what I mean. TennCare is our state health insurance, and anyone who doesn't have the resources to have their own insurance that they can buy are paid for by TennCare. So this is a very large group of people, and it is very effective way of monitoring what's happening in the healthcare system by looking at the data of TennCare. And what this slide is trying to show you is that it begins in 1995 to 2009, and the blue is when the women were exposed to opioids for 1 to 7 days. The red is 8 to 21 days, and the green is 22 days plus during the first trimester. There has been an incredible increase in the proportion of pregnancies with first trimester opioid use. And you can see here that the biggest change in these last 15 years or so has been those who received the opioids for 22 days plus. This ratio has gone up 8-fold. So it means that in the last 15 years, more and more mothers take opioids during pregnancy and expose their fetus to it. Now, this addresses the concern of my colleague who said that this is not a problem in Turkey. And use of analgesics in adult pain complaints, prevalence, and associated factors in Turkey. And really, we're talking about very high rates, 73%, very high rates in Turkey. So I would be very surprised if Turkey were different from the United States This is a big problem everywhere in the world. Doctors prescribing analgesics and the mothers becoming, if they're pregnant, becoming addicted. So how do we manage opioid dependence in pregnancy? Well, unfortunately, the treatment recommendations for opioid dependence in pregnancy have been derived from studies of heroin-dependent women. That's how those studies were done. And as I've just demonstrated to you, there has been a progressive increase in the proportion of the opioid-dependent women who are addicted to non-medically prescribed analgesics. Doctors find it particularly challenging to identify and manage these women, in part because a lot of the prescriptions come from them, the doctors. So the question we have to ask ourselves is, how does the presentation, the clinical course, and the complications of opioid dependence due to analgesics differ from or compare with that of heroin, if we want to extrapolate the data from heroin? And the story is nicely summarized here. During pregnancy, these women are exposed to a cycle of repeated intoxication and withdrawal. And of course, intoxication has specific effects on the mother. It causes respiratory depression, potentially aspiration, overdose. The consequence is hypoxemia for the fetus, acidosis, intrauterine growth retardation, and intrauterine fetal demise. Withdrawal, because if you are intoxicated and you stop taking, then you go into withdrawal, is associated with tachycardia, hypertension, nausea, vomiting, metabolic demand. And on the fetus, miscarriage, preterm labor, premature rupture of the membranes, IUGR, IUFD. So this is the story, this is the pathophysiology of what we're talking about. The complications of opioid dependence in pregnancy, I think, can be looked at in terms of two types of complications. One that has to do with neglect, the lifestyle of the mother, and the other that is distinctly related to the pathophysiology. Okay? So this means, these asterisks mean that these are primarily influenced by opioid pharmacologic actions, not the poor prenatal care and self-neglect that is often associated in these women. So the overdose, the intrauterine withdrawal, and the neonatal abstinence syndrome are related to the pharmacology of the opioids per se, whereas things like first trimester spontaneous abortion, meconium staining, antepartum hemorrhage, etc., these things, low birth weight, maternal neonatal infections, are related to the lifestyle associated with opioid dependence. Now, methadone maintenance has been demonstrated, very well documented, to reduce, basically improve prenatal care compared to active heroin addiction, increase fetal growth, reduce fetal mortality, decrease risk of infections, decrease risk of preeclampsia, the neonatal syndrome, abstinence syndrome, and also the last one, reduce foster care placement, means that the mothers are doing better in their addiction and there's no need to adopt out the children as much. But even so, neonatal abstinence syndrome is associated in more than 50% of the births, even in those who are opioid agonists maintained. So, do the benefits of agonist treatment apply to prescription opioid dependence? So the question is do we, if we maintain these women on agonist, is it, it's been shown to help heroin, does it help these analgesic dependence? Well, this is not fully established. We don't know whether the benefits of methadone maintenance during pregnancy demonstrated in heroin-dependent women may extrapolate to the non-medically prescribed opioid analgesics. However, the data suggests that it does. I mean, that maintenance is a reasonable strategy even in these women. Recent research in non-pregnant individuals treated with buprenorphine for prescription opioid dependence has shown that these patients who are analgesic dependent, if you stop giving them buprenorphine, they very quickly relapse. So it's basically, these patients are highly dependent as well. It's not just heroin-dependent patients who are so dependent. Analgesic-dependent patients also relapse very quickly, and so this episode of intoxication and withdrawal occurs if they are dependent on analgesics, not just heroin. Now, the differences in complications probably are attributed to the intravenous route of administration of heroin. So things like picking up HIV, etc., those things that are non-pharmacologic, those may be different. So, but clearly one other issue that is more important than anything else is that if you administer opioid maintenance in a structured, supportive program in which they can have good prenatal oversight, opioid maintenance, if it is delivered in a comprehensive program, it's likely to have benefits compared to the stressful and chaotic lifestyle associated with active addiction, whether it is heroin or prescription opioids. So the essence is the structured program together, and the agonists are what allows the patient to continue coming to that structured program. So opioid agonist medications, there are two currently available, methadone and buprenorphine, and really methadone has been the standard of care for the past 40 years. And we know that if we discontinue methadone once the child is born, there is the neonatal abstinence syndrome regardless. Buprenorphine is very effective now, we know, in non-pregnant women, and we are now starting to look at it in pregnant women, and this study that I'm going to talk to you about is in this population. Our hypothesis or our question is whether neonatal abstinence syndrome might be less with buprenorphine. So what is buprenorphine? And buprenorphine is it's an opioid partial agonist at the mu opioid receptor, and it's an antagonist at the kappa opioid receptor. In the United States, it's a Schedule III drug. Methadone is a Schedule II. Schedule II means that it's much more restricted legally. There is a legal, there's a law that came in called Drug Abuse Treatment Act of 2000 in the United States, which allows buprenorphine treatment to occur by qualified physicians, and it is allows you to have what is called office-based treatment, and this allows doctors in primary care and in specialty people in infectious disease, obstetrics, gynecology, psychiatry, and substance abuse clinics and methadone maintenance programs can now prescribe buprenorphine in the United States. I don't know what the situation here in Turkey is, but this is the situation in the United States. Now, buprenorphine has a high binding affinity for the mu opioid receptor. Just to make it, to summarize, affinity is the strength with which a drug physically binds to a receptor. But receptor affinity, whether it is strong or weak, is not the same as the activation of the receptor that occurs once the drug binds to the receptor. That's called activation is efficacy, how effective the drug is. The affinity of buprenorphine is very strong, so it binds very tightly to the receptor, and it displaces full agonists like heroin and methadone, and it actually acts like an antagonist under these circumstances. So in cartoon form, you can see here's the mu opioid receptor. The buprenorphine binds to this receptor very, very avidly, and therefore it displaces the full agonists. Now, buprenorphine, once it binds, dissociates very slowly from the mu opioid receptor. So dissociation is the rate at which a drug disengages or uncouples from the receptor after activation. The dissociation rate of buprenorphine is relatively slow. Once it binds, it doesn't want to leave. Therefore, buprenorphine occupies the receptor for a long time and blocks agonists from activating the receptor. So the cartoon is the mu receptor, and buprenorphine stays there. And it keeps the other drugs from binding. Now, if you remember, buprenorphine binds but is not very active at the receptor. It has only 50% activity than does methadone or morphine. So you can see here that a drug like heroin or morphine has 100% activation at the receptor. And if we look at buprenorphine, even though it has reached its maximum, this is only 50%. And so, buprenorphine can precipitate withdrawal if it displaces a full agonist from the mu opioid receptor, because it only partially activates the receptor, therefore resulting in a net decrease in activation. And this is the difference between the full and the partial. So if you have a person who's been on the street, a woman who's on the street taking heroin or methadone or whatever on the street, she comes in like this, you give her buprenorphine and she will go into withdrawal. Okay? So she has to be in withdrawal before you give her buprenorphine. Otherwise, you will cause withdrawal, precipitate withdrawal. So the study that I'd like to talk with you about today was published in New England Journal almost a year ago. The objective was to compare, for the first time, in opioid-dependent women, maternal and neonatal outcomes of treatment with buprenorphine or methadone throughout the pregnancy in an international, multi-center, randomized, controlled, double-blind, double-dummy clinical trial. And this diagram shows you that the women were initially contacted, they were screened, medical clearance was obtained, they were stratified into early estimated gestation age late estimated gestational age, and they were also stratified in terms of whether they had cocaine dependence or not. We had 8 sites. The medication that was given, buprenorphine or methadone, was in a double-blind fashion, double dummy, and by that we mean that the patient received the same methadone can only be given in a fluid form, whereas buprenorphine is given sublingually. So there was a placebo. Every patient got both the drink and the sublingual, but one was a placebo. They received flexible equivalent dosing based on symptoms. So they were made comfortable, and they received all the way from 20 to 140 milligrams of methadone or 2 to 32 milligrams of buprenorphine, depending on the group. These are the mother study sites, as you can see, from 3 countries, the US and Canada and Austria. The inclusion and exclusion criteria, they were 18 to 40 years of age. Their gestational age was between 6 to 30 weeks. They had to meet criteria for opioid dependence with opioid-positive urines. They were excluded if they had alcohol or benzodiazepine dependence. It had to be a single fetus pregnancy, and they planned to deliver in our hospitals. Now, there was a comprehensive care program associated with this. The women were part of a voucher program, whereas for every negative urine and breathalyzer result, they were given progressively increasing valued vouchers as gift certificates. And so this was a contingency management strategy in order to increase their compliance. They also received addiction counseling and education about healthy pregnancy and preparation for parenting and relationships, and they received excellent prenatal obstetric services and medical psychiatric care. So I should underline that the care they received was very high quality and probably more intense than they would receive in the real world. I think that's a very valid point. So it shows here that this is the consort diagram showing that of the 1,074 that were screened, 175 were randomized. And they were randomized to buprenorphine or methadone. And completion rates were 58 for buprenorphine and 73 for methadone. And a larger number discontinued, 28 discontinued compared to 16. And an important observation is that 20 of the 28 that discontinued buprenorphine discontinued it because they were dissatisfied with the medication. And although this was not statistically significant, it makes one think that there may have been problem with induction onto buprenorphine. And if by virtue, what I mean by that is, earlier on I told you how difficult it may be to take a woman who's actively on opioids to put them on buprenorphine without developing withdrawal. And I think that's what this may reflect. That it's more difficult to start buprenorphine than it is to start methadone. Once they were on it, they did very well. But the beginning is when, they dropped out. So this shows you the baseline characteristics of all the women who completed. There were no significant differences between the methadone and the buprenorphine group. When we asked the women whether they could tell us whether they were on methadone or buprenorphine. Remember, a lot of these women had already been on methadone. There was those who, they were not very good at guessing what they were actually on, suggesting that the blind was satisfactorily protected. And the nurses who were looking at the offspring, at the neonates, during the first few days of life, they also could not distinguish whether the child was on methadone or buprenorphine. Once again, the blind was well protected. Now, you know about neonatal abstinence syndrome. This was the major outcome of the study. This was the primary, what interested us most. The major hypothesis was that buprenorphine would diminish the neonatal abstinence syndrome. That was our hypothesis. The neonatal abstinence syndrome is characterized by neurologic excitability. The children are irritable, hyperactive, they can't sleep. Gastrointestinal dysfunction, they are uncoordinated in their sucking, they have problems with swallowing and vomiting, and they have a bunch of autonomic signs, including fever, sweating, and nasal stuffiness. And you can see that this is quite an irritable child, and this is quite a calm child. The primary outcomes of the study, you can see that the total amount of morphine prescribed to the neonate for neonatal abstinence syndrome was almost 10 times as high in the methadone children. And that the days the infant was in hospital was twice as long for the methadone children. Now the only significant, this is important because statistically we could only accept a significant result where the P was greater than or less than 0.0091. So for example, these are not significant. 0.03, even though you might think that they would be, they aren't, based on Bonferroni multiple comparisons. So I've indicated for you the only two that were significant. And these are the secondary outcomes. The days during which the child was treated for NAS was twice as long for the methadone than the buprenorphine group. And the other things, so for example, if you can see here infant length, the buprenorphine children were almost 2 centimeters longer, but that was not statistically significant because it was only 0.0049. We were very conservative statistically. Okay, and gestational age at delivery. There was a full 2 weeks difference in the duration of the pregnancy, but that was not statistically significant. But it was in the direction of benefiting buprenorphine. Many of the secondary maternal outcomes were not significant. None of them were significant, actually. And you can see, for example, none of them were significant. Now, this is interesting, and this is looking at the neonatal abstinence syndrome scores using the Finnegan scale. And you can see the open circles are buprenorphine, and the closed circles are methadone. And you can see that throughout the whole period, the methadone exposed infants had much more symptoms, okay, than the buprenorphine. But but there was no significant difference in the proportion that needed to be treated for with morphine, okay. So these kids were the buprenorphine kids seemed to be suffering less. A secondary set of analyses we conducted had to do with the maternal psychiatric symptoms during the pregnancy. I'm personally very interested in what it is, how common psychiatric disorders are among opioid-dependent pregnant women. And does the presence of psychopathology at study entry predict retention in treatment? And what are the implications of co-occurring psychopathology in these women for treatment of for their opioid dependence? So this is kind of interesting. We used, we screened the women using the MINI, which is a screening tool for psychiatric illnesses. There were 174, and you can see how high the rates of major depressive disorder, hyperthymic disorders, anxiety disorders are in these women. And do the presence of these symptoms actually have implications in terms of how well they do, in terms of the medical, employment, alcohol, drugs, legal, family, social, and psychological domains? We used something called the Addiction Severity Index, which breaks down levels of functioning in these different domains. And the bold letters indicate where there was a significant difference between whether the woman had psychopathology and did not have psychopathology in terms of the level of their functioning in that particular domain. And let me take, for example, if they had symptoms of MDD, 56 did, 118 did not, you could see that they had much more impairment in the medical domain than those who did not. And this was highly significantly different. So in general, even though we used the MINI, which is a screening tool, we were able to identify that presence of this psychopathology was associated with impaired functioning in all the domains. Now, the simple question we asked is that if they have either depression or anxiety on the MINI, what is the likelihood that they dropped out of the study? And you can see here that if they had signs of depression, that seemed to reduce the likelihood that they would drop out of the study by 74%. And if they had anxiety, there was a 7-fold increase in the likelihood that they would drop out of the study. So these are big differences. And if we, one of the points is that we only had a screening tool, not a diagnostic assessment. Okay? So what if we looked at depression, anxiety separately, and when we combined them, that they had both depression and anxiety? You will see that it's very common to have these together. In fact, anxiety is part of depression. And some people argue that depression is part of anxiety. But at any rate, there's a strong overlap. And you can see that 32% had both, met criteria for both. Now this shows you that if they had neither anxiety, this is the dropout rate with neither anxiety nor depression, depression only, both anxiety and depression. And you can see the statistically, even though depression seems to be protective, anxiety is the only one that significantly affected the outcome. And there was a large increase in dropout rates. So those who were more anxious were more likely to drop out from treatment. So what are the implications for clinical practice? Depressed women in opioid maintenance are less likely to drop out of treatment. And we don't know why, but perhaps this is because there is a significant antidepressant effect of opioid agonists. That opioid agonists affect the mood, and we often see patients who are quite depressed. You put them on an opioid agonist and their mood gets better. This may be important for the discussion this afternoon about antidepressants, but opioid agonists have antidepressant effects. Women with anxiety are much more likely to drop out of opioid maintenance. So, and we think that they may need individualized psychotherapeutic interventions or additional pharmacotherapy to assist in their retention. Now, this study was not able to look at the differential effects of methadone and buprenorphine on either depressive or anxiety symptoms because we didn't have enough subjects. But this would be very important to know. It would be very important to know whether some patients do better on buprenorphine and other patients do better on methadone. Just a few words about the management of depression in pregnancy. 10% or more of pregnant women have clinical depression, and this might be as high as 40% for opioid-dependent women. We know that if women are treated for their depression prior to pregnancy and they stop their antidepressant medication, they do relapse. There are significant fetal complications associated with untreated maternal depression. So if women go through pregnancy and they are depressed, the children don't do as well, even if they don't have addiction. So depression is not good for pregnancy. But data are lacking on the best way to manage depression in pregnancy, even in non-opioid dependent women. We don't know really how to treat depression in pregnancy well. There is a very big need to compare medications like the SSRIs with treatments, with other treatments to determine which are the safest, the most effective, and best tolerated. Ultimately, our goal is personalized treatment that optimizes the risk-benefit ratio and which allows informed consent, so the mother is a partner in the decisions. Remember, and this is when I started, in the 80s, there were lots of papers showing us how safe the SSRIs were during pregnancy. They said, SSRIs, there's no problems at all with SSRIs during pregnancy. Well, there is data emerging over the last several years showing various problems associated with the SSRIs. They're not big problems, but they're there. And even though there is no gross teratogenic abnormalities, there is likely to be behavioral teratogenesis. And this is now being defined to some degree. But children who were delivered from mothers who were on SSRIs have something called the poor neonatal adaptation syndrome. And interestingly enough, you look at these things, they're very nonspecific. Jitteriness, poor muscle tone, weak or absent cry, respiratory distress. In general, you can imagine how they would overlap with the neonatal abstinence syndrome due to opioid dependence. So it becomes a very murky picture when you look at these neonates. So what are my recommendations for the treatment of depression and anxiety in pregnant opioid addicts? First of all, remember that it's very difficult to diagnose depression in a pregnant woman because depression and anxiety is confounded by similarities in the signs and symptoms of pregnancy and opioid dependence. Pregnant women have aches, pregnant women have anxiety, pregnant women have a lot of the same kinds of symptoms that can be related to depression. So, very difficult to make the diagnosis, especially if it is mild or moderate depression. It's easy in severe depression, but not in mild and moderate. And remember that medication choice for depression and anxiety in these women should be significantly modified for two reasons. First, they are pregnant. You want to minimize exposure of the fetus to any medication unless absolutely necessary. Secondly, since they have co-occurring opioid dependence and are on opioid agonist treatment, opioid agonists themselves can help them feel better. They have significant antidepressant effects. The risk-benefit ratio is altered in pregnancy. Okay? The factors that you make, the factors that you consider in deciding whether to put someone on a medicine when they're not pregnant is different from when they are pregnant. The situation with medications. These typically take less time from the doctor, less effort, less thought. The cost is less, and insurance companies like you to give medications. There's a symbolic value for both the doctor and the patient. I'm giving you something that will make you feel better. The placebo effect is profound. But the benefits must be weighed with the potential toxicity of the medication for the fetus. On the other hand, one could use psychotherapy and behavioral approaches. These are very labor-intensive. They take a lot of time, effort. Quality control is difficult because, you have to be good at doing it, and there are many people doing psychotherapy, but it's very difficult to determine whether they're doing a good job. The cost is high, and insurance companies may say, well, just give them a medicine. So there are lots of benefits to psychotherapy and behavioral approaches and minimal toxicity. So I recommend that medications beyond adequate opioid substitution may not be needed in many moderately depressed or anxious women with access to good behavioral treatment and monitoring. For severely depressed anxious women who have had previous episodes with severe complications, cautious antidepressant prescription may be indicated. And targeting anxiety may be particularly important in treatment of the opioid-dependent patient because anxiety may be not as responsive to agonist treatment as depression is. So just in summary, these are the major findings of the mother study. Notice that the mean total dose of methadone, of morphine given to the infants was much higher in the methadone group, that the mean hospital stay was twice as high in the methadone, and that the mean duration of treatment for the NAS was also higher in the methadone. And there are some secondary analyses in terms of obstetrical outcomes in these neonates. Methadone and buprenorphine produced similar obstetrical outcomes in the context of comprehensive care, except buprenorphine treatment resulted in less suppression of fetal heart rate reactivity, and the biophysical profile score after medication dosing. And methadone maintenance was associated with higher incidence of preterm labor and a significantly higher percentage of respiratory distress. The clinical implications, in summary, the safety and efficacy of opioid maintenance treatment during pregnancy must be judged in the context of other services provided by a comprehensive treatment program rather than the medication itself, the agonist medication itself. Buprenorphine is not inferior to methadone. The standard of care, because methadone has been the standard of care for 40 years, but it may be preferable in terms of some pregnancy outcome measures. The safe induction of buprenorphine safely is very difficult, and it should not be routinely attempted. So what this means is that if a woman is actively using opioids when they come to you in the clinic, you do not want to put them on buprenorphine because you might precipitate a more severe withdrawal. Methadone may be safer. On the other hand, if a woman has been maintained on buprenorphine, then gets pregnant, don't discontinue the buprenorphine. Continue the buprenorphine throughout pregnancy because it's safe. So that's a really important point. Much research needs to be done on taking a woman from the street who's opioid dependent and putting them on buprenorphine without risk. That research still needs to be done. So let me close by being provocative, okay? And I've told you a nice story. Everything is clear. And now I'm going to tell you something that complicates my thinking. Shouldn't necessarily complicate your thinking yet. But there are reports of teratogenic effects of first trimester opioid exposure. And these must now be added to our risk-benefit considerations. The FDA guidelines currently recommend avoiding the use of prescription opioid. Do not currently recommend avoiding prescription opioids. So it's all right to use prescription opioids in pregnancy currently. However, animal studies do suggest the possibility of teratogenic effects of first trimester opioid exposure. First trimester exposure is in epidemiologic studies associated with significant increase in major cardiac and neural tube defects and a trend towards increase in major central nervous system defects. And this is from the CDC National Birth Defects Prevention Study by Broussard. The magnitude of necessary fetal exposure is undetermined. we are in the process of carefully looking at this evidence in the TennCare database that I showed you in the beginning of the presentation. You know, I think it's fair to understand that there is such an increase in the amount of these drugs used that if something as rare as abnormalities related to opioids in first trimester were not present 10 years ago, they may come out now because of the increased rate of use, of exposure of pregnancies to opioids. So there is a changing face of opioid dependence in the United States. I would suspect also in Turkey. Nowadays, everything can be achieved through a tablet, and including serenity, as you can see here. And this is an article from the New York Times recently about newly born and withdrawing from painkillers. This little child who was just born is now taking morphine because the mother was using painkillers. And this is the mother team from the different sites across the U.S. and Canada and Austria. And of course, this is a multi-center study, so we are just one of the 8 centers, but a lot of work went into these findings over 7 years, 8 years of work to put it together and to analyze the results. But I hope the findings are useful to you. Thank you very much.
Thank you, Peter Martin, for this detailed and comprehensive conference. I think we should aware about the opioid dependence in our country. Also, we have to learn how can we treat the opioid dependence. But I have a question firstly. Do you have any results about the long-term developmental consequences of the methadone treatment?
Excellent question. We are just analyzing the data now. In fact, when I get back to home, we have a conference call with the different sites where we're just preparing the publications now. We have followed the children from these pregnancies up to 3 years. And we are going to have some very valuable data where we will see whether there is a difference between exposure in utero to buprenorphine or methadone.
It will be interesting for us if we learn for the long-term developmental results for the baby, especially. Yeah. Thank you. Do you have any question for Peter Martin? Yes. Microphone, please. Mikrofonu verebilir misiniz arkadaşlar?
Dr. Martin, thank you so much for the lecture. That was very, very interesting and very thorough. Wanted to ask you, what are your thoughts regarding the use of, when a person is definitely already a patient who's suspected to having developed tolerance to opiates, then usually doctors in internal medicine or family practice, in lieu of hydrocodone or other preparations, prescribe tramadol. What are your thoughts on that?
Well, my thoughts are tramadol is not something I would prescribe. Tramadol is You know, the key thing is you want to have the woman have constant opioid use throughout their pregnancy. That's the key. It's better to use constantly than one day get intoxicated and 3 days later get intoxicated again. So that's really key. Tramadol is not a full opioid agonist. It's got a lot of other actions. And I think that the more simple you are with these women, the better. A question that I thought you might ask is, what if the woman has been getting opioids from their family doctor, like hydrocodone for their pain, and they're not opioid dependent? What should I do? I thought that would be the question you would ask, because that's one of the difficult questions. There's a woman who has been seeing their doctor regularly, and iatrogenically they've become physically dependent. They're getting their hydrocodone, but they're not using it abusively. They're taking it regularly. What should I do? That's the question I often hear from my colleagues. And my answer to that is, if the woman is not getting intoxicated and going into withdrawal, intoxicated and going into withdrawal, continue at the same dose. It's not necessarily better to be on methadone than on oxycodone. Okay? However, if the woman is using addictively, that they're one day getting high, the next day going into withdrawal, high, withdrawal, and they use oxycodone, they use methadone, and they use heroin, and they use codeine, and they use whatever they can get, then it's better to have them on one thing that's going to contain their addiction, reduce their craving, and have constant blood levels, and that's methadone. You see?
However, even though it could be a sustained non-abuse, let's say without any sign of abuse or misuse, wouldn't it be teratogenic during pregnancy, and would not be appropriate to consider maybe other pain medications such as, for example, acetaminophen or paracetamol?
Yeah. The trouble is that these women do relapse. Okay. If they're addicted, you can't just sit down with them and say, well, shouldn't you be using opioids? Because one day they're unhappy or things are not going well, and they will use opioids. And then the fetus will be intoxicated, and the next day the fetus will be in withdrawal. So the question is to maintain them as level as you can throughout the pregnancy.
Even for women who are not addicted to...
Even for women who are not addicted, because that's what the current data suggests, that women or people who are dependent on non-medically prescribed analgesics, okay, these are people that if they relapse very frequently. And so it's better to be level than up and down. That's the recommendation. Now, the other side of the whole thing is, some doctors say, well, the woman is on oxycodone, I have to take them off because it's better. Well, the question is, we don't yet know whether it's better to be off everything or to be on, and sometimes use, or to stay level. So.
Thank you very much, Dr. Martin. That was very inspiring. Some years back when I lived in Detroit, I had worked with addicted babies, and I have a thought. I'm wondering, and I'm not that familiar with the legal system. Obviously, it's different for different states, but it was a felonious act. This was back in the 80s for women to be injecting heroin when they were pregnant. And I'm just wondering, when I looked at your map, it seemed as though the incidences or the amount of active heroin use amongst pregnant women in that particular area of Michigan was somewhat lower. I'm wondering, first of all, if the legal system has made a difference in that. And second of all, there are probably still very many addicted babies that are born in prisons. And has any of this information filtered through to the medical doctors or psychiatrists who are giving care in that system?
You know, this is the differences in different places is something that's very interesting, and we don't fully understand why. Clearly, legal issues are one part. One of the bits of research that we're doing is that in Tennessee there is a physician reporting system whereby whenever a person goes to a doctor and they prescribe them a scheduled drug like opioids or benzodiazepines, they need to record it in a database. And so if the next 3 weeks later I see that patient in my office, I can go to the internet and I can see if they have gotten that medication from another doctor. And that's very, very important because generally when you see a patient, you don't know all the doctors they have seen before you, at least in the United States. And so they could be what we call in the U.S. doctor shopping, going from doctor to doctor. The issue in prisons is very different in different places. In some prisons, for example, they receive very good care. In other prisons, they receive very poor care. So they're allowed to go through withdrawal and all the bad things that happen. And in other prisons, they receive better care than the average population. You know, it depends on the state that you're dealing with. And then finally, there's one very, very important issue which you sort of touched on, and that is the issue of physician education. Okay? Doctors prescribe because they were taught to prescribe in a certain way. And, you know, if your teacher tells you that it's not a problem to use pain medicines, then when you practice, you use pain medicines. And if your doctor, you know, if your teacher tells you that in Turkey pain medications are not a problem, okay, then they don't think it's a problem. It's iatrogenic problems related to iatrogenic diseases are very, very much of a problem in modern medicine. So we have to look at our own practices in addition to our patients being addicted. Does that answer a little bit? Yeah, okay.
Başka sorusu olan ya da katkısı olan yok herhalde. Evet Mustafa.
First of all, I would like to thank Dr. Martin for this beautiful presentation. I would like to add something. There might have significant drug interactions with SSRIs and a painkiller tramadol. A clinician should be cautious or should be careful when prescribing an SSRI to the patient who has been taking painkiller tramadol. Thank you.
Katkın için teşekkür ediyoruz Mustafa. Başka sorusu olan yok sanırım. Thank you for this participation and excellent conference. I would like to give you a